And thank you to Jean Hales for inviting me to present to you this afternoon. I'm speaking about an area that I feel very passionate about. In fact, I've just stepped off the plane this morning from LA, and I was attending over there a conference from the Society of Family Planning, which had 1,200 very passionate healthcare professionals and public health people talking about how to improve family planning and abortion services in America. And when we talk about policy and political environments, it's very interesting that you can go to a conference like that and see so much innovation and so much amazing research being presented because I think the policy environment over there has actually catalysed people to act. So I hope that I can enthuse you also this afternoon about this area. I'm going to be talking about Sphere, our new centre, and how we are proposing to address the policy priorities in women's sexual and reproductive health in primary care that are part of the Women's Health Strategy. So Sphere is a newly funded $2.5 million National Health and Medical Research Council funded Centre of Research Excellence. And we're particularly focused on women's sexual and reproductive health in the primary care setting. And this recognises the really integral role of general practitioners and other healthcare professionals working in primary care in delivering services to what are about 5.6 million women of reproductive age in Australia. And if you think about the number of women and the number of services that they require, then my argument to you is where else can they get this kind of service except for primary care? And GPs are the backbone. We've got 35,000 GPs in Australia. And so Sphere's aim is really to get general practice and primary care more broadly working in the interests of women's health and really delivering very high quality, evidence-based, accessible services to achieve better outcomes. And when we pitched for Sphere, why primary care, why this area? Well, we're really not doing very well in a number of the parameters that we have to measure sexual and reproductive health. I'm going to talk to you a bit about these one by one. Our high rates of unintended pregnancy, lack of access to abortion, lack of best practice contraceptive service provision, lack of focus on preconception care, and what troubles me greatly is our workforce issues in this sphere. So let's talk about the high rates of unintended pregnancy and abortion that we have in Australia. Why is this happening in such a beautiful country like Australia, such a great universal health coverage? Why have we still got this problem happening? We know that about a third of Australian women experience an unintended pregnancy in their lifetime, and that about 30% of these end in abortion. And we also know that rates of unintended pregnancy and abortion are higher in those that are disadvantaged and those living in rural areas. And contrary to public opinion that this is a problem for teenagers, it's not. It's a problem for women who already have families, women of all ages, and our highest rates of unplanned pregnancy and abortion occur in women between the ages of 20 and 34. So one of the problems that causes unintended pregnancy, and it's only one of the causes, but it's a big part of the issue, is the lack of access to and uptake of the most effective forms of contraception. So in this country, about 66% of women use contraception, but the problem is that they're not necessarily using the most effective forms of contraception, which are the long-acting reversible forms. And we know that only about 11% of women are using things like IUDs and implants. And the problem is that they're not even being offered the choice of being able to use these products. So I'm focused on general practice, and when we reviewed the data that we have of what happens in general practice consultations, we found that only about 7% of contraceptive consultations that GPs were having involved discussion about LARCs. So there's lots that we can do to actually improve access to effective forms of contraception. We're starting from a very low base in Australia. Troublingly, despite having MS2-step, mifepristone medical abortion available on the PBS for a number of years now, this service has yet to become integrated into primary care. And access to these kinds of services, particularly in rural area, remains very problematic, with high out-of-pocket costs being a significant hurdle. Our colleagues at Marie Stopes tell us that from about August of this year, there were only about 1,300 certified GPs who could prescribe a medical abortion. That's out of 35,000, so a very small percentage. And we think even less than the numbers certified are actually prescribing medical abortion. So we've got a lot of work to do here also in terms of integrating medical abortion into primary health care. And this is an area of my personal interest. I've just been awarded a Churchill Fellowship to go overseas next year to bring back innovations from around the world to try and improve this issue. We also have a lot of problems in the area of fertility for women in Australia, with increasing numbers of women having trouble conceiving and increasing numbers using assisted reproductive services. There's a real delay in age to first pregnancy. I know when I talk to my patients about their pregnancy intentions, and my patients are 30, and I say, I might use the one key question or say, what are your thoughts? Are you wanting to have a child? When? Not for a few years, still got to get a mortgage and buy a house and get a job and do all these other things. 32 is the age of first pregnancy now, and 1 in 25 children are born using assisted reproductive technology, and 1 in 12 children born to women over the age of 35 are as a result of ART. That's got a lot of cost. Personal cost, emotional cost. It's got cost to the government, cost to the women, and there's additional morbidity that's associated with the use of ART as well. And so there's a lot of work that we can do in general practice and primary care around preconception care and trying to help women not only optimise their chances of getting pregnant, but also optimise their health prior to pregnancies. Also in the area of interconception care, we don't do very well at all. Women have poor outcomes in a pregnancy and then go back out to the community and nothing happens. Their lifestyle risk factors that may have contributed, or their chronic disease such as diabetes or hypertension or kidney disease or obesity is not addressed in the interim. So we need better ways of actually identifying women at risk. We need better liaison with hospitals to really identify high-risk women and offer them support to optimise their health and to achieve the best possible pregnancy outcomes. And while we're trying to do all of this and all of these big gaps are in place, we've got a real problem. So if you're going to take anything away from my presentation today, I think the most important issue that we have to contend with is our decreasing workforce capability. If I think about my GP trainees who are going to be the next generation of GPs out there, they do their residency in hospitals, but they're not actually seeing contraceptive services being provided. They're not seeing abortions being provided because these services aren't being done in our large teaching hospitals. The hospitals have very small numbers of clinics delivering these services, if at all. And with the larger number of hospitals that are faith-based, there is even less opportunity for our trainee doctors, nurses, pharmacists to actually see these services in operation. If you don't see them, you don't do them. And then they go out into general practice training and their supervisors aren't delivering these services either. They're not putting in IUDs, they're not delivering medical abortion. So where are our future generations going to learn these skills? This is a real problem. This is why we really want Sphere to try and create a paradigm shift in the way primary care delivers sexual and reproductive health services to women. In general practice, my colleagues, and I've been guilty too, if a woman comes in wanting contraception, we just deal with that. If a woman has an unplanned pregnancy, we might just deal with that. But we don't actually bring all of these issues together with preconception care as well to help women achieve their reproductive goals that they want. All of these issues are intertwined in women's lives, and primary care practitioners need to be able to deliver all of these services in a comprehensive, patient-centred way. So we've really got a lot of work to do to break down the silos and improve care. And this has a lot of alignment with the National Women's Health Strategy. The principles of achieving health equity, building capacity in primary care to do this, the priorities: increasing access to services, removing barriers, strengthening access pathways, and preventing or minimising the recurrence of existing conditions. These all directly relate to Sphere's mission and vision, and we're working hard on these issues. So our objectives are to generate new knowledge that will lead to improved health outcomes. We're also very focused on research translation, getting these messages into policy and into practice, trying to develop the health and medical research workforce, and we need to collaborate in order to do that. We've got 4 streams that we're focused on: abortion, contraception, preconception care, and we've got a very strong stream of health economics running through our centre to provide us with the evidence base for policy and practice change. This is our governance structure, and I'd just like to acknowledge here our partnership with the Jean Hales group in terms of their input on our stakeholder advisory group, as well as helping us to disseminate our work through their national communications network. Got a wonderful investigator team. We're multidisciplinary. My colleagues come from around Australia: GPs, psychologists, sociologists, gynecologists, epidemiologists, all of the great people that we need to work with. And I'm also delighted that we have our associate investigators who are key people from the field working in family planning organisations, in Marie Stopes from Jean Hales, and we have the best researchers, I think, in the world as our associate investigators coming from Europe and the United States, who are helping to funnel innovations through our centre and are giving us advice about the work that we're doing. We're working closely with partners around Australia, the Department of Health, the College of GPs, where we need to have a very strong relationship, which we've built, the College of ONGs, Pharmacy Society, Practice Nurse Association, all of these organisations. We've got to work together. This collaboration is essential in order to achieve the best outcomes. So I just thought I'd focus in finishing off on a couple of policy priorities that I think are doable now to help us achieve the outcomes that we want through the Women's Health Strategy. The first policy priority is about removing barriers for women and for practitioners. And one of the things that we could do very quickly would be to increase the Medicare rebate for LARC insertions. This has been recommended by the MBS review. The recommendations are there, very strongly supported by the sector to try and improve the uptake of LARC through general practice. Another thing that colleagues from Marie Stopes are working on is removing these requirements that are around being a prescriber of medical abortion. Our colleagues in Canada have completely removed all of the requirements around special conditions for prescribing in medical abortion. This is another hurdle for GPs to have to go online, certify, recertify after 3 years. Just adds to barrier and stigma around medical abortion. Another policy priority that we can work on is building our workforce capacity. Part of the reason there was such a zing at this conference in LA was that they've had this program called the Ryan Program in place now for many years. The Ryan Program is funded to offer practitioners Leadership, clinical and research skills in sexual and reproductive health. There are programs for gynecologists as well as for general practitioners, as well as for nurses. And they come together at this conference and they present their work, but they are the leaders of the future. They're really driving the momentum of this society through this program. It's something that we could very easily replicate in Australia. But because the issues around workforce are multi-sectorial in Australia, we really need to put together a task force that involves not only the College of GPs, but also the College of ONGs, ACRM, Pharmacy Society, Practice Nurse Association. We need to come together to work out solutions to this problem, because if we don't, it requires the input of everyone. If we don't come together to tackle this, we're really going to be in dire straits in the future. We need to be able to trial new models of care. And this is something that's on our agenda. This is something that's supported by the World Health Organization, that recognises the importance of task sharing in sexual and reproductive health, the very important role of nurse practitioners and of pharmacy. We need to move beyond the turf war between general practice and pharmacy to actually deliver best practice care and improve access for women. And these are issues that Sphere is going to be looking at. So we launched last month with the Senator Jane Hume, making the official launch of Sphere. The program goes for 5 years. We're very excited. I look forward to collaborating with many of you on our work, and look forward to meeting you at this meeting too. Thank you very much.
Afternoon, everyone. Just want to start by acknowledging the traditional owners of the land on which we meet, and also by thanking and acknowledging Jean Hales for their very much appreciated and very generous financial support to myself, and I'm sure the other fellows will express the same sentiment. It's an exciting program, and certainly when you're beavering away in your office late into the night writing grant applications, having a group as recognised and respected as Jean Hales to contribute to that work is extremely exciting and very much appreciated. I am a perinatal epidemiologist. I'm very interested in maternal and perinatal health in global health settings. I worked for some years in WHO in Geneva in a research role doing maternal health research and guideline development. I'm now recently returned to Australia. We're joining Burnet Institute, and I continue to work on predominantly global health, but having been out of Australia for several years, I've been excited to find intersections between some major global health priorities in maternal health and what's happening in Australia. So I do these days a lot of work on preterm birth and stillbirth, but have been working on caesarean section for a couple of years, and I want to share with you a bit about what we did at WHO and how it matters in the Australian context. Caesarean section is the most common surgical procedure that's performed worldwide. There are 140 million women who give birth every year, and our best estimate is something around 20% of those women give birth by caesarean section. So there's about 30 million surgical procedures that are being performed each year. And as best as we can tell, this number is increasing. The problem is that there is quite a wide disparity between countries in terms of caesarean section rates. As low as 1.6% in Nigeria and some other African countries, and over 50%. 56% of women in Brazil are giving birth by caesarean section. So we don't have a good grip on what is the optimal rate of caesarean section. And in Australia, just over a third of all births are occurring by caesarean section, and this is higher than other countries of roughly equivalent economic development at about 28%. It appears that there's a clear but slow upward trend in our caesarean section rate, so increasing from 30% to 34% over a 10-year period. Now, as far as we can tell, those CES rates are increasing because of both use of more elective caesarean section and more emergency or intrapartum caesarean section. But proportionately, it seems to be increasing use of elective caesarean section. Just to try to draw the link between why caesarean section matters and Given that it's a procedure that's been around for a very long time, and I think certainly in some cultures, in some parts of Australia, is a very normalised major abdominal procedure. But this is a key indicator of maternal and perinatal health service delivery. It's one of the indicators that WHO uses to assess, how well is a health system capable of delivering healthcare. What we do know is that mode of birth has a really profound effect. It's not just in terms of the health and well-being of mothers and babies. We shouldn't forget that caesarean section is and can be a life-saving procedure, but it can also be overused and abused. Caesarean section is associated with short and long-term health outcomes for mothers and babies. And as more evidence comes to light about understanding natural birth and understanding the physiology of normal birth, we're starting to understand that there are risks that we're absorbing by doing this procedure without a medical indication, perhaps that we may not come to fully appreciate for some time. It also affects a woman's birth experience and their satisfaction with that birth. And how the decision is taken around mode of birth is a very strong mediator of that experience. So I'm not saying that caesarean section is bad or natural birth is good. I'm saying that the process by which a decision around mode of birth is arrived at is an important process that can be done in a shared and collaborative way between women and clinicians. It also is going to affect women's decision-making about subsequent births. We know that having a caesarean section means that you can be at increased risk of other types of outcomes in subsequent births. So it may affect women's future reproductive choices as well. It seems that the use of caesarean section in Australia varies. It varies by ethnic origin, by geography, by age, by background. And while it's difficult to be very specific when you're talking about a phenomenon with complex drivers, however, there's increasing evidence, both direct and indirect, that caesarean section is being overused in some of these contexts. I want to give you a kind of a practical example. So the dark blue is high, and the sort of yellowish colour is lower rates. And these are just caesarean section rates from different geographical regions around Australia. So it's immediately striking that there's just a very high variation. Now, we know that there are obviously differences in socio-demographic characteristics in different parts of Australia, but do we really think that there are women in Australia who need caesarean section 3 times more as often as other parts of Australia? It doesn't stack up with what we know about the characteristics of that population. So clearly, somewhere amongst this, there's some misuse or inappropriate use or overuse. This is a very nice paper. It was published in 2012, trying to look at, what are the consequences of these inequities in caesarean section. When we think about caesarean in a global health context, we're thinking about countries and settings that have higher or higher than necessary rates, but we're also thinking about countries where the rate's far too low. We know that if you have, at a national level, a caesarean section rate getting up towards 10%, you're reducing maternal and newborn mortality. It appears to be beneficial. Now, somewhere between 10 and 15%, that relationship flattens out. We don't get additional mortality benefit, additional mortality reductions beyond 15%. So in this analysis, this group, some colleagues from WHO, were trying to cost out what's the consequence, the economic consequences of these medically non-indicated caesarean sections. And it consumes resources, and these are often in healthcare systems that have very few resources to go around. But I must say, I've never heard of a healthcare system that had more than enough resources to go around. So I think these arguments are very relevant even to high-income and to low and middle-income countries. While I was at WHO, I had the great privilege to be involved with a working group that came up with this 2015 statement, the WHO statement on caesarean section rates. It was a long process of epidemiologic analysis, systematic reviews, international expert consultation. What is WHO's position on these rising caesarean section rates and what should be done? So to summarise this sort of interesting and relatively brief document, WHO's moved away from this concept of a specific rate. The evidence does not back up that a specific population level rate should be targeted, because there are differences between countries and populations and health systems. Instead, the message needs to be that caesarean section should be available to those women who need it, rather than striving to achieve a specific rate. You can imagine that if you're in a country and you're saying, okay, we're trying to get to 20%, just delivering caesarean section to 20% of the women does not good outcomes make. It's about reaching the women who are in need and ensuring that they have access to it, rather than just making it available for everyone on demand. Well, how do countries actually operationalise this information? Well, there's a Robson classification system. I'm going to talk a bit more about it, but this is a tool that WHO is now recommending that all countries use as a global standard for assessing, monitoring and comparing caesarean section information. It can be used at facility level, at state level, at health system level, and also for international comparison. It wasn't just a system that was dreamed up. We're researchers. We love to do systematic reviews. If we didn't have systematic reviews, we'd go out of business. So in this review, our colleagues were looking at different types of classification systems, and Robson's a system that emerges as practical, easy to use, validated, replicable, and has been applied in a range of data sources and income settings. This quite sort of groovy infographic was our attempt to find a succinct way of presenting this information. But effectively, what the Robson system does is it takes all women who are giving birth and classifies them into 10 groups, mutually exclusive, all inclusive. You classify them on the basis of a few simple pieces of information that you can get from any routine birth register. I know this because we've applied this in data from countries in very low income and very low resource settings. It allows us to be much more sophisticated. We're not just looking at 34% or 20%. We're going deeper and looking at subpopulations of women and saying, okay, well, what's the use of caesarean section in this population of women, in women with multiple pregnancies, in women with previous caesarean sections? It's easy to use, easy to understand, and it allows us to make standardised comparisons. One great limitation in this field was, country A had been using their system, maybe an indication-based system, and country B had been using a whole different approach. We can't make meaningful comparisons. So this is a big part of WHO's job, trying to set global standards so that we can all collaborate more effectively and get to better outcomes. This was a paper we published a couple of years ago where we applied Robson to 2 large WHO survey data sets. These were from 287 facilities in 21 countries. So we were able to use Robson for the first time in several of these countries to actually make much more specific, diagnoses, recognition of what was driving the caesarean section rates and trends over time. It must be said that there have been champions for the WHO statement and for Robson in Australia, and I must commend those who worked with the AIHW to apply Robson to Australian birth data in 2015, and subsequently a couple of the Robson groups have become part of the National Core Maternity Indicators data set. However, looking at the literature just over the last 5 years, there actually are very few publications at state or at facility level of applying Robson. That's not to say that hospitals aren't maybe using it in a routine audit quality of care context, but it's becoming clear that we really haven't taken up the challenge to apply Robson in a meaningful way to try to optimise the use of caesarean section. Since returning to Australia and being in Victoria, we've been having some discussions with Safer Care Victoria and with the Consultative Council on Obstetric and Paediatric Mortality and Morbidity. And this has also been a research priority for them for a little while. So we're actually now applying the Robson classification to a cohort of over 700,000 births over a 10-year period. So this is some of the work that Jean Hale's very generous support is allowing me to do. An innovation that we're trying to bring to this work, to do something new, is can we be more specific about what hospitals could and should be doing? The reason we're excited about this is that people in hospitals often say, listen, our setting's different. We have a lot of high-risk women. We have a high burden of certain types of morbidity. We have no choice but to have higher caesarean section rates. So what we're doing is applying a model that we call C-model. We developed it in a cohort of 10 million women, looking at 3 million caesarean sections from 43 countries. What C-model can do is it takes the Robson information and a few extra bits of information about the women in your study, and it tries to make judgments about what would be a good caesarean section rate in your hospital based on other hospitals that perform well. Hospitals that we know have low caesarean section rates with great outcomes. So it'll give stakeholders, clinicians, policymakers some sense of, okay, are we too high, are we too low, where can we sort of aim, what goal can we give ourselves to try and optimise caesarean section usage? Of course, implementing these tools are not enough to change practice, but these new uses of large data sets in Australia are extremely exciting and can provide us with new and useful tools to actually improve and inform clinical practice and conform with what is now becoming the WHO international standard. So I just want to finish by, again, acknowledging the very kind support of Jean Hales. Thank you very much.
Good afternoon. I'm also a recipient of Jean Hales Postdoctoral Travel Fellowship, which is given to attend conferences and develop some new collaboration to take the research agenda on women's health forward. Before I share how I have been utilizing the Travel Fellowship, I would like to give an overview of what I have been doing in women's health domain. So as I've been introduced, I'm a perinatal epidemiologist, but I have a special interest in evidence synthesis on maternal, newborn, child, and adolescent health and nutrition interventions. So one of the very initial work that I have done included reviewing global evidence on essential interventions for reproductive, maternal, newborn, and child health, in which we actually reviewed 142 interventions on reproductive, maternal, newborn, child health and identified 42 very essential interventions. And this work has been published as a WHO guideline back in 2012, and we have also published the series of papers in reproductive health back in 2014. Taking the same work forward, as we all know, women and mothers and babies' health is intertwined. We looked at the impact of interventions delivered during continuum of care on newborn health and survival. So we actually reviewed a total of 58 interventions from over 148 Cochrane and non-Cochrane systematic reviews, and identified 6 very effective and 11 promising interventions that are delivered during the continuum of care and have an impact on improving the neonatal health and survival. I've also looked at the global evidence of providing packaged interventions in community settings. So these packaged interventions usually comprise of several interventions outlined in this table, which are grouped together and delivered to communities. And these have actually shown impact on improving maternal morbidity, decreasing neonatal and perinatal mortality, improving the uptake of clean delivery kits, improving the rates of institutional deliveries, early initiation of breastfeeding, and overall healthcare seeking behaviors in women as well. We took this work forward and also identified what are the strategies that can improve the uptake of these packaged interventions. So we saw that when these packaged interventions were combined with community mobilization or with home visitation and community mobilization, they had greater impact on improving healthcare seeking among women and children, particularly in marginalized and low-income settings. In 2010, the preconception care started to gain interest, and we conducted a series of systematic reviews and on over 35 interventions that could be delivered during preconception period, and we identified several very effective interventions that can improve the health of mothers and babies later in life, and that included prevention of teenage pregnancy, uptake of contraception and family planning, nutritional counseling and optimization and weight loss program, the multi-component youth development programs including sexual and reproductive health, screening and management of chronic diseases including mental health. With preconception health, adolescent health agenda also started gaining interest. And we know that adolescent is the critical stage in life where lifelong health behaviors are formed and future health trajectories take shape. And again, we conducted several systematic reviews on interventions that could be delivered in adolescent health, and it has been published in Journal of Adolescent Health in 2016. And we found, conducted systematic reviews in nutrition, coverage and access to immunization, mental health, substance abuse, and interventions to prevent unintentional injuries in adolescents. We particularly conducted systematic reviews on adolescent nutrition interventions that included micronutrient supplementation, balanced energy, protein supplementation for undernourished adolescents, and obesity prevention and management. And we also reviewed the guidelines on adolescent nutrition. And we found that there were paucity of trials in adolescent nutrition, and most of the guidelines that have addressed adolescent nutrition were the evidence were mostly coming from adult population or adult pregnant women. So with this fellowship, I was able to attend Women Deliver conference back in June 2019 in Vancouver, which was on gender equality. So I'm very thankful to Jean Hales for providing this fellowship. And there I actually presented and shared the project that I've been planning with Birthing Kit Foundation Australia on sexual and reproductive health. But this not only helped me in attending the conference, but helped me meet the experts and build some new collaboration, which also includes a collaborative work with researchers from University of Alberta. So I was very fortunate to build these collaborations. So they not only invited me to take part in their research projects, but also invited me to be a joint applicant to some of the fundings where they were applying. So these are some of the programs, some of the projects that I have been doing with them, and these are some of the grant applications that we have prepared and submitted. With this fellowship, I was also able to attend the Lancet Nutrition Review meeting in Toronto in June 2019, where my involvement was to take lead in evidence synthesis on maternal nutrition intervention, preconception care intervention, and several other nutrition-related topics. And this work is in progress and will be published in Campbell Systematic Review, will be published in Nutrients Journal, and the evidence coming out from this work will then be fed into Lancet Nutrition series, which is due to be published in 2020. The collaboration or this meeting also helped me in a way that they also invited me to take part in a workshop in Lancet Child Health Optimizing Series workshop. So I would be working and I would be a working member on this Lancet series as well. So I'm very thankful to Jean Hales because I received so much of recognition as well. So my work is not only in low and middle income countries, but I'm also finding ways to improve the health of women and babies in Australia, and one, especially those in disadvantaged and marginalized settings. And one such project is Young Aboriginal Health and Wellbeing. So in this project, we are gaining perspective from young Aboriginal people living in Adelaide about how they view health and well-being. We are identifying opportunities to enhance existing youth health programs and services to meet their express needs. And the overall idea is to identify future opportunities for interventions in the preconception period that are tailored to the specific needs of the Aboriginal people. We are also analyzing the data set from Department of Education and Child Development from over 40,000 children from 2017, where we are actually trying to find out the association of breakfast skipping and bullying in young adolescents in South Australia. So from the very initial analysis, we have found that breakfast skipping was prevalent in almost 20% of the children, South Australian children, and now we are analyzing its relationship with the bullying and body image. I'm also collaborating with Birthing Kit Foundation Australia, who have international development programs in Ethiopia, Uganda, and India. And the projects that we are developing is around adolescent sexual and reproductive health, and future projects would be around safe childbirth using clean birth kits. So thank you, and I'm very, I want to acknowledge my supervisors and mentors who, without their support, this work would not have been possible. I'm very grateful to the funding from Jean Hales and NHMRC for my fellowship, and yeah, University of Adelaide.
I'll also pop up there the one-pager, which is a summary of the 4 questions that were asked at the forum, so that you've got that as a bit of a memory jogger. All of the slides and presentations at the end of the symposium will be uploaded onto the Jean Hales website as well, barring any that are not able to for any reason. So you will have access to the information that's out there, but just so that you've got memory joggers for this afternoon, I'll put those handouts up there next to the board, and I'll let you wrap up.
Thank you. Thank you. I think it's been a really interesting afternoon, and we started with the overview from Erin on previous forums before moving into Danielle's session, really emphasising the importance of primary care in this space, which is so absolutely critical. Joshua spoke to us about his fantastic work looking at caesarean section and how we can optimise rates in Australia. And the wonderful research that's being done in that field. And Zora, I'm exhausted listening to all the wonderful work that you are doing, and again looking at what kind of interventions do work in this space for what kind of communities. I think just pulling it together, some of the things that have been emphasised for me is the importance of the life course approach, because of course we don't experience phases in our life and one comes to an end and another begins necessarily. It's quite seamless as we live our lives, and what has gone before impacts on what happens next. So it is a life course approach that we need to take, and that's been brought home to us, I think, in this session particularly. The other aspect is the importance of a primary care approach, that there's so much to be done in the primary care area, including preconception, but just helping individuals be the most well in a holistic sense, and the benefit that brings to everybody's life, whether or not they come into an acute service at any different time. Part of that for me as a midwife, what I take away from this morning is the importance of judicious use of interventions. We do, I think, have a love affair with technology, and I think we're often a little bit too willing to grasp that next thing, whether it be a medicine, a technology, a gadget, but they bring consequences. Nothing is benign in this kind of space. So really careful, judicious use of technologies, I think. And partly for me, the mesh debacle, that we've recently had with women's bodies, I just feel so saddened by that women's bodies felt to me like they were experimented on, and so many women are having devastating effects from that. So whatever we do, first do no harm. Workforce is another factor I take away from this morning, and also about collaboration. So intersectorial collaborations, reducing those silos, but also interprofessional collaborations, because we have a whole range of health carers in this space. They bring unique perspectives, different skills, different knowledge, and they all have a place. And I think we can reach further if we really do exploit the skills and experience of our whole workforce. So thank you. Thank you to the speakers and panel members. I really very much enjoyed the morning, and thank you, Erin.
Thank you. Sorry, all my stuff.